Welcome everybody to Advanced Pharmacology. This is maybe your first PowerPoint that you're watching, or I don't want to say PowerPoint. Anyways, this is going to be quick, but I do want to go over prescriptive authority and advanced practice registered nurses because maybe many of you want to go on to be some sort of advanced practice registered nurse. So this goes right along with chapter 1 in your textbook. Before we do anything, you should really know what an APRN is, right? So APRNs in some states, you'll see them still as APNPs, which is Advanced Practice Nurse Prescribers. But the one thing I want to get straight is that not all APRNs can prescribe. So if you see in the first sentence, nurse practitioners can prescribe, clinical nurse specialists at this point are unable to prescribe. Nurse anesthetists, it varies state by state, and nurse midwives, it also varies state by state. Here in Wisconsin, the only profession that can, or only component that can prescribe are nurse practitioners. There is something called the APRN Modernization Act that is in legislation right now, trying to get everybody to be able to prescribe. There's a lot of barriers to that, including the Wisconsin Hospital Association. So to go back down, I said not all APRNs can prescribe, and it also varies state by state. So if you go to page 2, you'll see some states of APRNs that can prescribe and cannot prescribe. Now, remember when a textbook comes out, it's sometimes a couple years old. So I will provide some links on exactly which states now, but we have about 22 states in the United States. 22 states that can prescribe, where nurse practitioners can now prescribe independently. Most all states, nurse practitioners can prescribe medications, but some need supervision and some need collaboration, and some are not allowed to prescribe narcotics. But how do you learn more about what APRNs do? Well, the American Nurses Association is excellent for learning about the overall umbrella of APRNs, as mentioned above: NPs, CNS, nurse anesthetist, nurse midwife, to see where direction you might want to go. If you want to learn more about nurse practitioners, then you can go to the AANP or ANCC, and that is where you will take your board. So after you go through an NP program, you choose AANP or ANCC to take your certification exam in order to practice. Which one do you take? Well, it just depends. There's really no preference to which one. ANCC does include more research type questions, and it also seems to vary by a university and area within the United States. There's pockets that usually you'll see AANP versus AANC. All right, prescriptive authority. What is that? The legal right to prescribe drugs. It depends also, and there's some limitations for in some states by MDs and DOs. We have the American Medical Association that's really a barrier to our independence. So we've been fighting for that, as I'm a nurse practitioner. This is very important to know. What are controlled substances? Those are narcotics. They're scheduled 1 through 5. And so when we go and prescribe narcotics, we need to know what scheduled drug it is, why we're prescribing it. But how did this come about? These are placed in their schedules based on currently accepted medical use and their likelihood of abuse. I rarely ever prescribe narcotics. There are some, though, that are in the schedules that I do prescribe, but again, it varies. If you work in a pain management clinic, it's different. Nobody prescribes Schedule 1. These are heroin, LSD, and now I know there's legislation to try to get marijuana off Schedule 1 drugs, because now it can be prescribed in some areas and as well as legal in some states. But everything else is a Schedule 1. Schedule 2 are your Dilaudid, Demerol, which is really prescribed, but your fentanyl, oxycodone, these are the things that have been abused, and we, as prescribers, we're really monitored by the DEA, and we have to report anytime we prescribe a narcotic to the Prescription Drug Monitoring Program online. If I prescribe a narcotic for someone, I need to go check that patient and see if they've gotten that drug anywhere else. I don't want to start an abuse issue with my patient. And if I do prescribe, the rule is only 72 hours maximum. Pain management is completely different. So there's some Schedule 2N, which is your Adderall, Ritalin, and I do prescribe Adderall for patients because I do work in mental health. Again, there's rules that have to do with that, and I'm always checking the prescription drug monitoring program. Schedule 3, a little less addictive, but still addictive. This is your Tylenol with codeine, your Suboxone. There's Suboxone and methadone clinics that people get off the oxycodone and the fentanyl and end up taking Suboxone or methadone chronically. Or they go the other way and start Schedule 1, which is heroin. As we all know, morphine's derived from the poppy plant. It all goes down. Even Tylenol with codeine. The codeine's a derivative of morphine. Schedule 4 is your alprazolam. Those are your benzodiazepines to help with anxiety. These are highly abusive too. Alprazolam, clonazepam, diazepam, all of those with the PAM at the end. Soma, it's a muscle relaxer. It's been notorious for causing addiction issues. It has a lower potential, but the problem is out there. Schedule 5 drugs are your Phenergan with codeine, your Robitussin AC, which is the cough medicine. And I've had patients that really love their Tylenol with codeine or their Phenergan with codeine, and I had to really put a stop to that. All right, so what are some components of prescriptive authority? If you go again in your textbook and read about that, you'll find that there's some states that have supervision, some that have collaboration, and some can do it without any limitation. We can go ahead and prescribe. In Wisconsin, we can prescribe schedules 2 through 5 without um, having as much oversight. We have to have a collaboration, but with COVID, there's actually been an emergency order in place that we can function independently. So we're hoping that it stays that way. Regulations are another component. It's determined by state law. Providers may have full prescriptive authority in some states and restrictions in others. So it just depends. And there's a lot of stakeholders. We have the State Board of Nursing, the State Board of Medicine, the State Board of Pharmacy, as well as other, such as hospital associations that have barriers. So it's a fight for every state for APRNs to prescribe. And full prescriptive authority, there's still maybe some regulations, like we have to do some continuing education every 5 years or even every year to keep our prescriber's license. I have to pay for a prescriber's license, and I also have to pay the DEA. Prescriber's license is expensive. The DEA is about $800 about every 3 years, and the prescriber's license is, I think, over $100 every couple of years. So I'm not going to read through all this, but just know that in order to have full prescriptive authority, there's regulations and there's rules you have to follow, as well as money you have to pay. It's a huge responsibility. You have to know exactly what you're prescribing, the side effects, who you're giving it to. And if you go back to the scheduled drugs 1 through 5, for example, if we go back real quick to these clonazepam, I prescribe clonazepam again because I work in mental health, but I do it carefully. And if it's prescribed the way it should be done for a short amount of time, then it's safe. So it goes back to having responsibility. And that is it.